Hi, everyone. We're going to get started with our event today. We'd like to welcome everyone to our Allied Health Speaker Panel, hosted by the Department of Health and Society. It's so wonderful to see you all today. We have a full agenda, so I'll keep my remarks brief. But before we begin, we'd love to collect your emails so we can engage you in a short survey. All of a sudden, this doesn't want to work. There we go. So if you don't mind scanning the QR code and providing us with your emails in the coming days, we'll send you a little survey, to get your insight on how you felt today's event went and what you would like to see for future events. Everyone that provides their email is going to be entered into a raffle to win a bag of swag from our department. Today's agenda is, I don't know which way you're supposed to hold this. There we go. So here's our agenda for today. Our chair, Professor Michelle Silver, will begin with a brief welcome and introduction, followed by our panelists who will share their educational and career journeys, what inspired them to enter their professions, what they enjoy most about their work, and their thoughts about the future of their particular fields, including what a typical workday looks like for them. After the panel discussion, Dr. Pablo Galvez Hernandez, Assistant Professor in Health and Society, will lead a fun interprofessional case study. In this activity, we'll explore how each of our panelists in their respective professional roles would approach a single medical case, highlighting the breadth and importance of allied health in today's healthcare system. We'll close with a Q&A and networking session, so please stick around to connect with our speakers and one another. Just a quick note that there is another event in this room scheduled at 2, so we'll have to promptly wrap up at the end. Help yourselves to lunch. I don't know if you've all seen, but there's a lot of beverages on the side there. So please don't be shy. And now please join me in welcoming Professor Silver, who's going to introduce our panelists.
Hello, good afternoon, and welcome everyone. It's my distinct pleasure to welcome you to today's special panel event. Today we have the unique opportunity to learn directly from a range of amazing allied health professionals. Allied health professionals are the backbone and the heart of our healthcare system. They're the hands, the voices, and the compassionate hearts that support and empower patients every day. Whether it's the nurse practitioner managing emergencies, the physiotherapist helping someone regain movement, the speech language pathologist restoring voices, the clinical psychologist helping someone regain their sense of self, or the social worker advocating for patients. Each work tirelessly at the front lines and behind the scenes to improve lives in ways that truly matter. You are here today because you're feeling the call to be part of this extraordinary team, or you're at least considering it. The healthcare system needs people like you, people who bring comfort in moments of fear, strength in times of struggle, and joy in the journey of recovery. We're incredibly grateful to have such a talented and dedicated set of speakers with us. These are people who've walked the path and are now lighting the way forward. Dr. Hasina Amanzai is an emergency room nurse practitioner. Raymond Chan is a physiotherapist. Serena Appalsamy is a speech language pathologist, working with Kayla Collymore, a communicative disorders assistant, and both are return speakers to our events. Jenkins Mock, a clinical psychologist, and Gregory Serieaux-Halls, a social worker. I encourage you to listen, to be curious, to let their stories inspire you, and to embrace the profound impact that you will have on lives moving forward. I want to say special thank you to our support team, Sean Ramerton, our amazing program coordinator who you just heard from, Sephra Appalsamy, our extraordinary chair's assistant, and our most recent faculty member, Dr. Galvez Hernandez, who's going to lead the case study today. Thank you for choosing this meaningful journey. The world needs your kindness, your commitment, and your courage. So let's go ahead, and without further ado, we'll turn it over to each of you. And thank you.
That's better. I'm usually a loudspeaker, so I guess I didn't need the the microphone. I'm really delighted to be here. Thank you so much for inviting me, and it's really an amazing opportunity to meet with allied health colleagues outside of my practice. So I am a nurse practitioner. So nurse practitioners in Ontario are advanced practice nurses. They are able to prescribe, diagnose, admit patients and care for patients of various ages. I've had a very long educational journey. My life began as an RPN, so registered practical nurse, that usually care for lower acuity patients. So that's a 2-year college program that I had done. And while doing the nursing program, I had received a lot of encouragement from patients, from teachers, from family to continue learning. So I did the bridging program at Centennial College after that. And then I decided to become an RN. So I did 2 more years at Ryerson, which is now called Toronto Metropolitan University. And then I started practicing in the emergency department as a registered nurse. But I was also practicing with the vulnerable population, so newcomers, immigrants as well, in the community also. And then I did my master's after that. So at University of Toronto, downtown campus, I did my master's degree as a nurse practitioner in primary care. And I started working as a nurse practitioner in the emergency department since. So I work in a very small community hospital. It's in Cobourg, Ontario. I am one of the few nurse practitioners that have stayed there for a long time. And I love my practice of working in a smaller community because I do have a very broad scope of practice. There's not a lot of providers in that area. And I also maintain a practice in the community with a very different population. So I work with immigrant newcomers as well. So 2 different areas, emergency department and in the community setting, in a family practice sort of setting, I also work. And I always loved education and teaching. And so after I became a nurse practitioner, I started teaching at TMU at that time in the NP program, but also in the undergraduate program as well. And along that time, I also became involved in research. So I do have a program of research that focuses on the health of the elderly population, newcomers, immigrants, and also those that are more of the racialized backgrounds as well. And then I did my PhD, so it didn't stop after that. So I did my PhD in urban health, and it was an interdisciplinary program, which was wonderful because it was not just for nurses. So various other healthcare professionals could also do the PhD as well. And my PhD focused on looking at menopausal symptoms in South Asian women in general, and looking at lifestyle interventions that we often prescribe to our patients, which are not completed. And I wanted to understand why these lifestyle interventions are not completed. What are the barriers to it? And so I did my PhD in urban health, and I'm currently a full-time professor at the Toronto Metropolitan University, and also a nurse practitioner as well. So I have a practice as well as a full-time teaching role. What inspired me to pursue my career? I think I've already said enough. I mean, my long education and journey itself is a source of inspiration. I believe that my students, the learners that I've worked with, always have inspired me to continue learning. And I think that nursing in itself is a profession that allowed me to not just care for patients, but to grow as a person, to be able to care for very, very diverse communities, and to be able to work in various roles as well. So that was a source of inspiration. What I love about my work is that every day is different as while working in the emergency department. So I could be caring for a child that just has the flu and that child becomes in respiratory distress, or I could be caring for a senior who is just here because they felt a little confused and the next thing we know they have a stroke. I think that I have a very, very challenging role as a nurse practitioner, but that role is always dealt with in a very good way because we always work as a team. So I don't manage patients on my own. I always also collaborate with other team members as well. And I think that as nurse practitioners, we are growing in the province of Ontario. the role of nurse practitioners continue to expand. There are nurse practitioners work independently, so we do not need a provider, a physician, medical director. So we're able to work on our own independently. We're able to prescribe medications. We're able to discharge patients, admit them to hospital settings. So we're not just working in the community and clinics, but we're also working in hospitals. We're working in long-term care settings. And I think the role will continue to expand. There's a huge need for the profession. I believe that in the upcoming years, we will be able to have more and more nurse practitioners, and hopefully the funding will continue for that. And aside from my hospital day, which usually starts very, very early and ends very, very late, I also have a typical day in the university as well. So that involves teaching. My role as a professor at the university is not only teaching, but it is also based on service to the university. So being on various committees, and also having a program of research as well. So I do research on regular basis. I currently have a few studies that I'm doing. We're looking at transnational health practices among refugee older adults. We also have a study looking at barriers and facilitators to physical activity in the immigrant population. And I'm also looking at menopause in the racialized communities and women in general. So yes, I think that's all about me for now. Thank you so much. Thank you.
Hello? Oh, pretty loud. Okay. So yes, my name is Raymond. I'm a registered physiotherapist. I've worked over 15, I have over 15 years of experience. I currently work as a full-time clinician at a clinic called MaxMobility Physiotherapy and Wellness. It's located just south from here at Morningside and Lawrence. We specialize in orthopedics, so I treat people with musculoskeletal disorders. In terms of other services we provide there, it's massage therapy, physiotherapy, and we also sell products such as custom-made orthotics, orthopedic bracing, and compression stockings. So a little shameless plug, if you're interested in any of the services or products, you can feel free to contact me after this. In terms of my education background, I did my undergraduate degree at the University of Waterloo, where I studied kinesiology. And then after that, I did my master's of physiotherapy at the University of Toronto at the downtown campus. So I'm a UT alumni as well. In terms of what made me pursue a career in physiotherapy, it wasn't really straightforward, to be honest. I actually studied environmental engineering. And if you ask me why to this day, I still don't know. I didn't know what I wanted to do after I was finished high school. So I did some research and I just thought I would choose something that would please my parents. And also maybe had a good job outlook. And so lesson learned, please pursue a career that you're passionate about. And I hope that it will lead to a great path in the future. But going back, I was halfway done my engineering degree, and unfortunately, but luckily, I suffered a pretty bad hand injury while playing volleyball. And I saw the doctor, and he recommended me that I wear a splint for about 6 to 8 weeks. And then he recommended that I did some physiotherapy. And I said, "What's that?" So that was my first exposure to the profession, in which I saw the physiotherapist, and the experience was just eye-opening. The way that she took care of me, gave me exercises to do, knowing when to wean off using the splint. I thought it was almost miraculous how she was able to get me back to my full recovery so quickly. And when I saw her interact with other patients, as well as the whole clinic setting, working with her colleagues, that's when I realized that that was what I wanted to do for my career. And that's how I wanted to help people. And I think that in the healthcare profession, I think that is the reason why we all get into it in the first place, is that we want to help people. So I think that's one of the most rewarding parts of my career, is that I have a direct impact on helping someone improve their mobility as a physiotherapist. I get to guide them into improving their activities of daily living, which can range between just getting out of bed, sitting to standing, getting out of the chair, and most importantly, walking and reintegrating with the community. In terms of what my typical day looks like, my current role as I'm a full-time physiotherapist that specializes in outpatient musculoskeletal disorders. 90% of it's clinical. So I see about 10 to 15 patients a day. I average about 30 minutes with them. I assess, diagnose, and manage their MSK disorders. And going back to what Dr. Hasina says, we are independent providers as well. You don't necessarily need to see a doctor in order to see us. So we're not primary care providers, but we are direct access providers. So going with that, going back to what I was saying with the clinical work that I do, I collaborate with the family doctors, walk-in doctors, as well as the other allied healthcare professionals, such as massage therapy, in order to improve patient outcomes with any shared clients that we have. The 10% that's kind of non-clinical is more admin work, dealing with payroll, just renewing inventory, and then also not collaborate, but also consult with insurance companies. So if patients aren't paying out of their pocket or using their extended healthcare benefits, then I would consult with the WSIB, so the Workplace Safety Insurance Board, for patients who suffered from a workplace accident, as well as auto insurance companies for patients who suffered a motor vehicle accident injury. And we would discuss their prognosis, their progress, as well as when they can be discharged. As for the future of physiotherapy, I think the job outlook is great, by the way, over the next 5 to 10 years. One of the great things about being a physio is that we can work in many different environments. We can work in the hospital, we can work in the community, such as myself, or we can even work in the home setting with patients, as there's a growing demand of home care physio as a result of patients possibly being discharged, not too early, but early discharge from the hospital. And also one thing I want to note that is that when people think of physiotherapy, you might maybe think of, oh, you work with athletes or people with sports injuries. I think that's far from the case. We also specialize in neurological disorders and cardiorespiratory disorders. So one of the great things I find about the profession is that we can work in many different environments, and also we can work with many different types of people who need our help. Going back to what I said in terms of the job outlook being great over the next 5 to 10 years, the reason why I think is great is because of two things. One is that there's a recent growth in our population in Canada. I think it's grown to about 41 to 42 million Canadians now. And also the baby boomers today, they are 60 to 80 years old. So for you, all of you out there, they could either be your parents or grandparents. And I guarantee you, if you ask them how they're moving, they're probably going to complain of knee pain, low back pain, maybe just even having a hard time getting out of bed or moving up and down the stairs or just walking out there. So our services are needed now more than ever. And the baby boomers today, they represent the second largest demographic in Canada, just behind the millennials, such as myself. So I think that's a lot of talk from me. I hope that helped a lot. And if you have any questions, feel free to ask.
Hello, everyone. I'm Serena Appalsamy, speech language pathologist. I'm currently registered with CASLPO, so that's the College of Audiologists and Speech Language Pathologists of Ontario. So everyone who is practicing as a speech pathologist in Ontario does need to be certified and registered with CASLPO. Currently, I'm a pediatric SLP, so I'm working only with children, and this ranges from different types of speech sound disorders and motor speech disorders. I help kids with also learning how to read, who are having difficulties with reading. We're also working with kids with a language delay, so kids who need early intervention, so the babies who aren't talking yet and aren't meeting their milestones. So right now I work within my own private practice called Sparks of Speech. So Kayla and I actually co-founded it together. We service Durham region. And right now I only do home visits and virtual therapy within the Durham region. So my educational pathway, I am UTSC alumni. So I did come here and completed a specialist in psycholinguistics. And then I decided to take an adventure to Australia to do my grad program in my master's of speech language pathology. And I also overcame my fear of spiders over there. So, yes, I'm one of those lucky people that knew I wanted to be a speech language pathologist from the time I was 16. This all happened at a careers day in grade 10 at J. Clark Richardson, my high school in Ajax, where I met two lovely speech pathologists who worked for Grandview at the time. And they asked, "Hey, do you know what a speech language pathologist does?" When I was walking by, and I was like, "No, I do not." And they just started telling me what they do and how they work with children and help support communication development. And and that sounded cool to me, but I wasn't sure. I kind of knew I liked working with kids, but I was open to volunteering. So at that time, I was like, okay, you know what? I had no idea at the time what I wanted to do, but I knew that I liked working with kids. So I took up the opportunity to volunteer. And when I saw what they do and the amount of fun that they have, like the amount of fun this career brings on a day-to-day, we're playing with kids, but how we work language intervention and goals into that play to inspire communication. So from that volunteer opportunity, it actually opened the doors to more volunteer opportunities within the speech language pathology field. So after that, went on the pathway, looked into what I needed to become a speech pathologist. So a specialist in psycholinguistics at the time allowed me to take a lot of the prerequisites needed to complete a graduate degree in speech language pathology. So linguistics, or you're looking at phonetics, so speech sounds. Is anyone doing psycholinguistics or linguistics here? Yeah. So I'm sure you're doing some syntax, phonology. Yeah. So a lot of studying of language and so that was pretty much that. And after volunteering at Grandview, I also did some research opportunities as well. So I was also a research assistant at University Toronto St. George campus in the speech pathology department because I wasn't sure, okay, maybe I like the research side of things. So my advice right now to you guys too is take on the volunteer opportunities that you're presented with. Go on, look into research, explore what you enjoy doing because of that one volunteer opportunity, it helped shape where I am today. And I'm so passionate about working with kids. Kayla and I know she'll also share her excitement and passion for this field as well. So what I most enjoy about my field of work is working with the kids. So most days we're actually creating intervention plans around supporting communication. So for example, one of my first kids today, I'll be working with who has something called apraxia, childhood apraxia of speech. So they have a motor speech disorder. So we're working on supporting sounds. How can I get this child to produce sounds? Do they have to work on opening their mouth to make the ah sound, or we're working on lip rounding? Then my client after that, a late talker, they aren't speaking yet. So how can I use play within the session to support that language development? So it ranges day to day. And that's what I love. The variety in the career, the different presentations, it helps to always be a challenge as well. And in terms of the future of our profession, it is growing. So in terms of speech language pathology, identification of neurodivergent neurotypes is increasing. So we have a lot of kids who are being new referrals to the clinic who have a diagnosis of autism. And there's not many speech pathologists who are actually within the communities who can service the demand right now. We also have a lot of kids who are being referred with reading delays or reading disorders, and not enough support within the school setting to actually help support these kids with learning to read and write. So there's that literacy aspect to our career as well. And then in terms of the amount of private practices within certain areas, there's not that many. So as much as demand is increasing, there's not many speech language pathologists in our environment to support the demand right now. So we do, encourage, if you feel that you're enjoying linguistics and working on language development, 100% there is going to be jobs within the next 5 to 10 years. And in terms of a typical workday right now, because I am working for the private practice, it's very much right now a schedule that I've created for myself that works great for me. And that's one of the luxuries with working within private practice. So right now I typically see around 6 clients a day. So in the mornings, I'm not a morning person. So I do wake up around 8:30 and then I'll go for a little walk because I do like to start my day with a walk. And then I'll look at my caseload for the day and who I'm seeing. I might do some prep for the day in my clinic. And then I head off because we only do home visits. I'm driving from client to client. But what I've done is I've planned it by location. So for example, today I'm only in Ajax, so I'm only driving around in Ajax to client. And then, I end my day and then start over the next day. So the flexibility within the private practice setting is something that I really do enjoy and works well for me. So yeah, once again, the one thing I do love and would stress to you guys is that there's so many different environments that we can work in as a speech language pathologist. So be it in private practice, or if you do like more of the hospital setting, we do work with adults, which we'll get to visit with the adult case study later today to understand a little bit more about what we would do if we were working with adults. We also work in the school board setting as well, where you are working to support staff and how to support communication within the school environment. But yeah, that's pretty much all from me. I'm going to pass it on to Kayla now.
Hi, everyone. My name is Kayla. I am a CDAAC, Communicative Disorders Assistant. It's a long title. It's basically a speech pathology assistant. And currently, as Serena mentioned, we co-own a private practice in Durham region, which we started in 2021. And my educational pathway is all over the place. I started out at UTSC, so this was my home building, and did a Bachelor of Science in Linguistics and Psychology, so pretty much psycholinguistics, same thing. And that's where Serena and I met in first year university in Lynn A01, Linguistics A01, and we developed a friendship and said, one day we'd love to open a business together, and it just manifested that way. And so started out U of T, did my 4 years here. Then instead of going directly into the Master's of Speech Pathology program, I decided to first do a Communicative Disorders Assistant graduate assistant program at Durham College. And the interesting thing about that program is that speech therapy assistants can actually work in speech, or we can actually also work in audiology. So it gives you a nice broad experience. So you spend half your time working on speech and learning about speech strategies and communication disorders. And we also learned about hearing and how communication support therapy assistants can support in audiology clinics. We made hearing aid molds. We learned how to do hearing tests. So I would, do hearing tests on patients, check hearing aids, do any sort of hearing support. So it's an interesting program if you want to kind of see which one you're leaning towards. If you want to maybe go into audiology, if you want to go into speech therapy, it's a good way to kind of test it out. And there's a lot of hands-on experiences in that program. I had 2 amazing placements at Holland Bloorview and Toronto Rehab Hospital. And after that program, again, I started working as a communicative disorders assistant, and I actually just recently finished my master's degree. So in speech pathology. So I'm in the process of getting that licensing. So I'll come back to that actually in a second. But what inspired me in this career, same as Serena, early on in high school, I knew that I wanted to work with kids. I actually thought I wanted to be a pediatrician first. And then grade 11 and grade 12 chemistry and physics happened. And I thought, you know what? I don't think med school might be for me. So I was trying to figure out what other careers could I do that involve kids, involve health. I love, working with others. And my mom said, what about speech pathology? I'd never heard of it before. And so I decided to just do a quick Google search and Googled 3 different SLPs, one that worked in the hospital, one that worked in the school, and the one that worked in private practice. And I had they were all very willing to talk to me. I had a quick 5 to 10 minute conversation with all 3 of them. And I thought, wow, sounds really cool. I would love to get into this. And so similar to Serena, I also started volunteering at the Aphasia Institute. So I was working with adults with aphasia, with a communication disorder, expressive language disorder, and loved it. Was here at UTSC. I was going there by bus, getting there, doing my volunteering, going to work. It was a bit hectic, but similarly, that experience really opened my eyes to how broad this field is and how amazing it kind of just matched with my personality. So yeah, I would say that my mom inspired me because I had no idea what this field was, but pleasantly surprised. And so what I enjoy most about my work is, again, working with kids and getting to be creative and passionate, and also even above the working with kids, because I have had experience working with adults as well. My first job actually was at Toronto Rehab Hospital, which was actually from one of my placements in school. And in that role, I was working with stroke patients who had been recently diagnosed and had language difficulties, and I would actually be programming communication devices for them. So they weren't able to really communicate verbally or very minimal verbal speech. And I would talk to their family, talk to them as much as possible, get all their information, put it into a communication device that they would be able to, press a button and say, "Hi, my name is Kayla," or "I need to use the bathroom," or something. And it was very life-changing to be someone to help break down communication barriers, because all of us, we talk so freely, so easily, but when you realizing you're with someone that doesn't have that ability, or that's a struggle, it really makes you appreciate the ability to communicate. And so I really enjoyed that role. And again, in that role as well, I was going around doing hearing screenings on patients, going through in the hospital, checking people's hearing aids, making sure they're functioning. So there's so many aspects to speech pathology. I recently finished up, again, I mentioned my master's, and my last experience there was in acute care. Which is another aspect, again, where we're pediatric focused right now, but SLPs also work with adults who are in the hospital, who have difficulty swallowing. If you've had a stroke, your swallowing muscles can be affected, and speech pathologists are the ones who help to give diet recommendations. Like, is it safe for this patient to swallow a certain texture? We work really closely with dietitians. We actually work pretty closely with a lot of people on this panel in the hospital setting to help make sure patients can swallow safely and communicate effectively. So it's really broad. If you like the kids, there's something there. If you like working with adults, there's something there. If you like really medical focused work, there's acute care. If you like more desk work, there's that too. So there's something for everyone. And as Serena mentioned, the future of the profession is really bright. I think, with the demand, again, in this region, like, for example, the wait list right now for speech therapy services in the schools, or even publicly funded through Grandview or another service, is about 3 years. So there's kids waiting like up to 3 years to get services, to get speech therapy. So there's a lot of need. And obviously just not enough people, and also not enough funding, but that's another conversation. But so yeah, there's lots of opportunities, and I think there's something for everyone if this is something that sounds like you might like. Currently, my typical workday is a little bit crazy. So I would say 3 months ago, before I recently finished my master's degree, Serena and I, again, in private practice, you can make your own schedule. So sleep in, go to the gym, see clients kind of in the afternoon, maybe go to a coffee shop, get some notes done, and then go home. Currently, because as Serena mentioned, every new clinician, new speech pathologist needs to be registered with Ontario. It's like a 6-month mentorship process. So in the day now, I'm actually in TDSB doing a clinical mentorship. So I'm working with students there. And then after that, I'm seeing kids from our own clinic. So it's a little bit hectic, but it's all part of the process. I've been doing this is my 6th going into 7th year. And I couldn't see myself doing anything else. I think it's something that, yeah, really, really suits me. And it helps me to really feel like I'm making a difference, especially when you're working with kids who, again, are late talkers, don't have that access to language, or you're working with older community who've had a stroke and need help regaining those skills or working on compensatory strategies. So I think that speech pathology is a great field. It's booming, and if it sounds interesting, we're happy to chat with you after.
Hi, everybody. My name is Jenkin. I'm a licensed clinical psychologist, registered clinical psychologist here in Ontario. I'll try to keep my part streamlined so Greg has a chance to speak as well. Just to sort of speak first of, a lot of people often ask, what a clinical psychologist? What is that? How's that different from a psychotherapist, a psychiatrist? That's a great question. Sometimes I ask myself that too, but mainly it's because we have all of these different professions, including some of my fellow colleagues here, all have a contribution to the healthcare system. As a clinical psychologist, I'm one of very few limited healthcare professionals who can diagnose and communicate a diagnosis of a mental health disorder. So that's one thing that I think being a clinical psychologist, I really pride in and sort of speak to. More specifically, as a clinical psychologist, I focus in specific areas of competency. So I work with adults, so roughly between the ages of 18 to 64. I'm a clinical psychologist, and if you think of that as someone who assess and treats various different mental health disorders and concerns. I'm also a rehabilitation psychologist, which will be very much aligned with our case study later on working with folks with neurological impairments or acquired brain injuries such as stroke, and sort of helping to treat and support that individual back into their day-to-day sort of functioning. I'm also a neuropsychologist, which means that I often work with a lot of folks who are dealing with various cognitive impairments as a way to sort of help better understand how their cognitive functioning impacts their day-to-day functioning, impacts their mental health. So it's an intersection of a lot of different areas and scopes of practice. Just like Kayla and Serena, I am also a UTSC alum, and I'm very happy to tell you exactly by dates and timelines. So you can kind of count how old I probably am. I started at UTSC in 2010. And did a 4-year undergraduate degree in neuroscience and mental health studies. For me, I think just like a lot of folks on this panel, the trajectory was not very linear. I started off as a neuroscience specialist in the co-op program, transitioned into a double major in neuroscience and mental health because for me, I found that as I became more enamored with the possibility of becoming a clinical psychologist one day, that intersection between those two programs of neuroscience, understanding the relationship between brain and behavior, and the mental health practices really helped sort of cement what I wanted to do. And I would say in terms of what really sort of helped me gravitate towards this, it's really the quality of education and research opportunities that came at UTSC. It's very much known that in the 3 campuses of U of T, UTSC has a very intimate sort of environment where, unlike maybe some of our counterparts at U of T St. George, you don't get an opportunity to really interact with your professors and the folks that are the academics that are here. That was not my experience. It was an absolute blessing to be at UCSC because I got to interact with my professors. And those were the sort of really important mentors that helped cement me into this career. And I remember being in the ARC in the evening, taking up normal psychology or neuropsychology with Dr. Rocco. And that helped impassion this possibility. Through my undergraduate studies, I had the opportunity of being able to volunteer and through work study, work in various psychology labs and mental health settings. And from there, I transitioned into eventually a honors thesis, which gave me the, I think, academic and research background that helped me to then transition into my graduate studies at York University in the neuropsychology program. So that program was a little bit lengthy. It was a 2-year master's program followed by a 4-year PhD. Through those 6 years, that included a lot of coursework that was both applied and theoretical. And then at the same time, the part that I really was enamored to was the opportunity to actually build my clinical experiences through practicum. So Toronto Rehab, Sunnybrook, Baycrest, these are hospitals here in Toronto and the GTA that focus on varying mental health concerns and neurological concerns that I think really help capture, I think, the experiences. As a psychologist, especially one who practices in neuropsychology, one of the works and responsibilities that we do is understanding how someone's cognitive functioning through various assessments, different tools, we can better understand how that highlights what that person's day-to-day experiences are like. And I think those really in-depth experiences, being exposed to these types of individuals and these populations, really helped reinforce that appreciation of the profession and understanding of what that work and responsibility is. After the lengthy period of master's and PhD, in which I also was involved in research, academic research. I did a 1 year of residency at London Health Science Centre. I was working at both of those hospitals, as well as the University of Western Ontario within their psychotherapy counseling clinic center. So really got to interact with a lot of students like yourself. And I also did the same at York as well, being able to sort of see both sides of like what it means to be a psychologist, both in a hospital setting, as well as more in more of a community-based arena. And ultimately, that's where I think I felt like I gravitated more. So after my after my residency, 1 year of residency, I transitioned into supervised practice, which is where you do your licensing exams, where you complete your independent clinical hours working with clients and patients. And I did that in more of a private practice setting. And here I am, 2025. So you could probably sort of see the trajectory here. I'm a licensed clinical psychologist, and just sort of like that idea, I think, sort of resonates with, I think, from maybe what you can hear from me, like the passion I think I have when it comes to the work that I do. My day-to-day consists, because I am in private practice, of that opportunity for flexibility. So I get to see the number of clients that I'm able to see. I work with clients from an intervention or therapy point of view. So working with folks one-to-one for about an hour each time on talk therapy, psychotherapy, interventions. I also see clients from the assessment lens. So folks who are struggling with their mental health or who are experiencing various cognitive concerns, and what is ultimately the reason why behind it. Being able to be on both sides is a very important part, I think, of being a clinical psychologist, because not only are you assessing and diagnosing and determining what you think are the best outcomes for this individual, you can also then transition into supporting that person. And I think that's a critical part of my work as a psychologist. The last thing I want to speak to in terms of the future of our profession is a very interesting time, because there are two, I think, major areas that are being spearheaded by our college, the College of Psychologists and Behavior Analysts of Ontario, as well as the province of Ontario. The first one is actually expanding the scope of practice for clinical psychologists. Currently, it's under what's called a public consultation phase of psychologists potentially being able to prescribe medication. So very similar to a nurse practitioner. The other side, which will probably be of interest to some of you, is that there's a lot of talks about changing the curriculum of the training for clinical psychology. So potentially decreasing some of the barriers that it takes to get into the programs and being able to eventually practice as a psychologist. So those are two avenues that are really, there's a lot of lengthy conversations being had right now about what that would look like. And that really speaks to our profession really trying to evolve, because as we all know, mental health care is health care, right? So I'll pass it off to Craig.
Thank you so much. My name is Greg Serieaux-Halls. I have a HBSc from here at UTSC, so I'm a UTSC alum as well. Also have a master's in social work from UTSG, and I am a registered social worker with the Ontario College of Social Workers and Social Service Workers. My educational pathway was also nonlinear. So I started out here at UTSC. I had an idea of what I wanted to do coming out of high school. I wanted to work with children and youth. I wanted to find a position where I could teach, but not within kind of the structure and with the limitations that came with teaching in a classroom. So I wanted to try to find a pathway through the community. But in high school, I took a lot of business classes. So I started here actually in the management program, and then got through my first year. And my plan initially was, okay, I'm going to get this business degree so that I can open a business on the side while I'm working with children and youth. I was very ambitious. And then first year happened, and I said, I don't want to be in school for that long. So what's the quickest path that I can take to get me into the field that I want to get into? And so I pivoted. In my third year, kind of scrapped it all, started over with first year courses, kind of running the gamut. And I took first year psychology, and I fell in love with psychology. And so I graduated at a time when they were still offering 3-year degrees. So I graduated with a major in psychology, and then I got into doing children and youth programming, which then branched into doing program facilitation with also parents within the school board. And then I branched into both working with children and youth and as well doing programming with adults. And I was facilitating an evidence-based program that leaned heavily on the developmental psychology theories that I had learned, which was really validating because a lot of times you learn something in school and then you just kind of forget about it and you scrap it. So it felt very validating to be facilitating a program and have an understanding for kind of the theory that went into it as I was working with children and families. But part of this program, there was a group component and there was an individual component. And even though I was not yet a social worker or not yet a counselor, because I was one of the facilitators on the program, my organization decided that if the participants felt like they built enough rapport with me and trust with me, that they could do their one-on-one sessions with me. We just weren't allowed to call it counseling because I wasn't a counselor, but I was providing counseling. And I found a lot of times I was running into situations where, because there's this trust and rapport built, my clients would disclose like really traumatic parts of their past and of their history that I was in a position where I was not equipped to really be able to provide them with the support that they needed. And I was working with a team that had social workers on it. So I was able to provide referrals to the social workers that were a part of that team. But that is where kind of my spark for social work kind of emerged, because I wanted to be in a position where I could provide that support instead of having to provide that referral. So I worked in the community for probably like 15 to 20 years. Within that setting, also supporting adults with developmental disabilities, and decided in COVID really to return back to school so that I could pursue the master's and get an MSW. Because I graduated with a 3-year degree, I first had to come back and upgrade my degree. So at the time, it was kind of early COVID. So everything was online, which, being a working professional and having a family actually really fit in with my life at the time. And so I returned to UTSC, albeit virtually, and I completed a sociology major. And that really opened my eyes. So initially, I just wanted to get into social work so that I could help on the individual level, on the ground level. And completing the sociology major really opened my eyes to a lot of the systemic and social issues that are happening in the world. And so my passion going into and coming out of my MSW was I want to do both. I want to work with individuals. I want to continue to do therapy and help individuals, but I also want to try to contribute to social and systemic change. So now I have my MSW. I am currently working in a private practice. So I am treating individuals and also working with couples. My practice holds couples retreats, so also I'm able to continue working with groups while I am still doing research, actually with a lab that's based out of UTSC, that's looking at improving health equity for Black communities in Canada. And I am using that to build towards, I actually submitted my first application for a PhD program this past weekend because I want to continue on this academic journey and be able to kind of access the spaces that I would need to in order to be able to impact the change kind of at a systems level that I would like to do. So that's educational pathway and what inspired me to pursue my career. What I enjoy most about my work is just getting to know people. I think as a social worker, and it was mentioned, like social workers are able to do a diverse array of things from psychotherapy to doing research and advocacy, case management, which is connecting clients to resources that they would need within the community. Social workers work also in a diverse array of settings. So we have social workers working in hospitals, in clinics, private practice as well. So what I enjoy most is just getting to know people. Clients having the trust to like bare their souls and share their stories and share their pain and share their trauma. And being able to walk with them through that and kind of just be a mirror and having kind of the mindset and the approach that my job is not to fix anybody, but as I learn about clients, I help them to learn about themselves and to grow and to be able to impact the change that they want to in their lives, and seeing when I have time with clients, them actually taking steps and coming to those realizations about their own lives and seeing their lives improve and seeing their mindsets change is one of the really most rewarding parts of my work. As for the future of social work, there is a lot of movement with social workers moving into private practice and opening private practice. There's a huge need for social work, as you know, society is, as mental health is becoming less and less taboo to talk about. We see how many people really need that support. And so there's definitely still a growing need for social work and for social workers. There's also, I see more social work getting connected with allied health teams, working not just in hospitals, but connecting with clinics, with family physicians, and other allied health professionals, and being able to work collaboratively in settings like that. And I see that only continuing to grow in the future. A typical workday for me, there really isn't one. Because my mindset was geared towards part of my work being geared towards the clinical side and working with individuals and couples, and part of it being more systems related, I have 2 days a week that I dedicate to seeing clients, and that's individuals and couples. And I have the research that I'm also doing, which is interspersed throughout the week. And I also am still continuing to work in person with adults with developmental disabilities 3 days a week. So it really varies. And oftentimes I don't even know what day of the week it is. You'd have to ask me like what responsibility I have on that day, and then I'll be able to tell you what day of the week it is, because it varies. But I really enjoy that. I really enjoy that my days are not similar, and that there's variance in there, and that there's a lot of room for growth within that.
Thank you so much to all the speakers for these introductions and this overview of what a day looks like. And we'll move into the case study, but before, as I was listening to them, something that I reflected on is, well, regardless that they're all really exam professionals, passionate, but all of them mentioned something in common that they were, as they were progressing in their career journey, they were embracing several trial, error, reassessing whether the current situation suit them. So I think this is a key learning, like when we are following our passion or future careers, like keep reassessing and keep having patience and an open mind, being open-minded to get to the point where we want to be. But as you can see, this might take several years. So I think this was a great example of hard work and to reach your goals. Yeah. So having said that, now we'll move into an interprofessional case study, and our patient will be a person that experienced a stroke. So this will be a hypothetical scenario where we'll follow the care journey of that person across several settings like hospital, primary care center, community center, and we'll see how each professional might respond to the needs of this person at different time points. So if you have questions, we'll have some time for Q&A after the case study. And so now what I will ask is for each speaker, we'll have around 2 to 3 minutes to discuss when they will be involved, like at what stage you think you will be involved, and what your involvement will be, as well as if you think about potential collaborations. So before we jump into the, I pass it to the panelists, I will give a bit a background of the case. So the name of the person is David Singh. He's a 58-year-old male. His medical history includes type 2 diabetes, hypertension, mild depression in the past. And the current event involves that he recently experienced an ischemic stroke affecting the left side of his brain. So now he has right-sided weaknesses, speech difficulties, and challenges with daily functioning. Regarding the social context, he lives with his wife, who is the primary caregiver. He has adult children that live out of the province, so they are pretty isolated. And they are experiencing a financial stress due to inability to return to his previous job due to the current stroke. So to summarize it, what are the presenting challenges? So David Singh has physical weakness and difficulty walking, expressive aphasia, which is trouble producing speech clearly, emotional distress, which involves symptoms such as frustration, low mood, fear about the future, increased caregiver stress for his wife, complex medical management needs involving blood pressure, diabetes, recovery, several medications management, and concern about financial stability and social supports. So this is the background of the case, and now I'll pass it to Dr. Hasina Amanzai.
Yep. Okay. So I'll talk about the case just very briefly in terms of which levels I might be involved in. So because I work in the emergency department and I also work in the community, I could potentially be involved in various phases of this case. So for example, Mr. Singh just is experiencing some weakness, stroke-like symptoms. They bring him into the hospital. So that would be one of the stages where I would be getting involved. Usually the triage nurses will assess him first. And, come and let me know that we have a gentleman here in triage and we think that he may be having a stroke. So I would get involved by doing a very thorough assessment and find out what of some of the signs and symptoms that he's showing up. Usually with stroke, we have a very narrow window of ordering things. So working in a smaller community hospital on a Saturday morning, it's usually me and one other provider, and we can get anything off the 401 that comes in through our hospital. So I would definitely be more and more thorough in this case, but also making sure that he gets a timely assessment. So by assessment, it's not just the physical assessment, but ordering some of the blood work as well as the CT scan, which is what we usually do when we have someone coming in with a stroke. So we have CT scan capabilities at our hospital, so that would be something that I'll definitely be looking at to identify whether the gentleman is having an ischemic versus hemorrhagic stroke and how bad are the symptoms and what we may be dealing with. And if I'm seeing this gentleman, for example, after he's had a stroke, I mean, he's had a stroke about, let's say, a week ago, 2 weeks ago, and now he's back in the community, but he's having some more challenges, for example, with swallowing, and the wife thinks that he may be having, um, you know, a pneumonia because, he swallowed something and he has swallowing difficulties, and for that reason he might be having some respiratory distress, and I'll be seeing him in a very different way. So I'll quickly assess if vital signs, see if I might be dealing with an infection versus an ongoing issue. Is this acute or is this a chronic problem that's happening? And based on that, I will also again order the tests. With individuals that have strokes, we have, in this case, this particular patient has a few pre-existing issues. So we have a diabetes, which is already a risk factor for a stroke. We're dealing with a hypertension. And then working with this community closely, with the South Asian community, we also know that they also have familial dyslipidemia and other risk factors, so they're more prone to having various heart conditions compared to other populations. So if I'm seeing him in the community, or even if it's in the emergency department, I think it would be important to do additional testing as well. So not going beyond the CT scan, I would be looking at carotid Doppler. So those are ultrasounds of the neck vessels to make sure if there's any blockages that are happening. And what sort of lifestyle interventions we can do to help reduce the amount of blockage or the progression of his risk factors. And it's also very important to note that I would not be looking after this patient independently, especially in a primary care or in a chronic care setting, because other colleagues that are here, speech language pathology, social work, as well as physiotherapy, will definitely be involved. So this gentleman has weakness, I'll definitely be putting a referral to our physiotherapy colleagues, to help them with mobility. We don't have occupational therapists here, but that is another healthcare provider or member of the allied health team that would definitely be involved to do a home assessment to see if there is any challenges within the home, if this individual is able to walk, or if there's a lot of clutter around their house, they will have to do that sort of assessment. And then with swallowing, so if we're prescribing medications, if we're worried about his nutrition needs, swallowing has to be assessed. And that will not be something that I would be doing. I'll definitely be putting in a referral to SLP as well. His medications, and so all medications are some things that I could order as a nurse practitioner and I could prescribe. So there's no limit on the medications that we could prescribe as nurse practitioners. And also having a regular follow-up for him. So most patients nowadays have an issue of not having a primary care provider. So we could do the best emergency care that we can, but then we send them back to the community and they fall through the cracks. So we want to make sure that there's follow-up in place for them. So whether that is a diabetes center or some sort of a community health center where we can link this patient to a follow-up, I would definitely be doing that as well to make sure that they get follow-up. And if I'm seeing in the community, if I'm one of those providers, which most NPs do work in the community, then we want to make sure that there's regular follow-up for his diabetes. So that would be one thing. So seeing him on quarterly, about at least 4 times a year for his diabetes management aspects, working closely with his physiotherapist to make sure that he gets the aids. And then there's also the caregiver aspect and emotional needs as well. So those are things that I could help with, but definitely I would consult with psychology or clinical psychologists in that perspective as well. I would also be as nurse practitioners, we don't just look after the patients. So we work with communities, we work with families. So definitely I would be working with their partner as well. Caregiver burden is one of the things that people don't often recognize. So in this case, if there is any language barriers, for example, if they come from a different background where they're older, they don't speak the language, what kind of help is this family receiving in terms of caregiving services, or what kind of help does the partner need to support this person better? And warning signs of complications. So if the person is actually not able to swallow and the caregiver is still feeding them with the regular diet, that might be a problem. So in that case, we want to make sure that we do a swallowing assessment on them and to see if there is a need for this patient to be in a different setting versus their home? Are we providing them with the care that they need? Are they receiving the support that they need? So those will be some of the things we're looking at from a nurse practitioner's perspective. And yeah, I can pass it on to physiotherapy.
Thanks. So for physio, once David is medically stable, I believe he would be admitted to a dedicated stroke unit at the hospital, which can happen around day 3. That's where I would start to play my role as a physio. I would do early mobilizations, functional screening, and assess his physical disability status. So given his right-sided weakness and difficulties with daily functioning, I would expect David to be triaged in inpatient stroke rehab. So that would be, he would be admitted into the hospital for the rehabilitation. And for inpatient rehab, that typically can take between 3 to 6 weeks, more or less, depending on how well David recovers. One thing I think it's important to note is that the most rapid recovery after a stroke occurs during the first 3 months after a stroke, because that's where the brain has heightened neuroplasticity, where they can relearn the most lost skills. So it's very critical that David starts early intervention immediately. So that would include SLP, speech language pathology, physiotherapy, and OT. So in terms of the numbers, I would see him minimum 1 hour per day, 5 to 6 days a week, if he can tolerate it. What I would do with David during these sessions, I would try to prevent complications such as contractures that would reduce his range of motion, any existing shoulder pain that can happen as a result of the right-sided weakness. And the focus would be more on stimulating his affected side. So his right side is affected, so it would be upper extremity and lower extremity. How would I do that? It would be called forced use therapy, where I would try to encourage David to use his right side of his body and not to compensate with his left side of the body. And with that, the focus is using functional exercises. So functional rehab is what includes synergistic movements. An example of that is, say, for example, David has a weak quadriceps muscle. I wouldn't get him to go to a gym and do, those machines that you see at the gym, like sitting knee extensions. That's not going to work. I would get him to do sit to stand, like this, in order to strengthen his quads, because that's more functional for him, and that's the best way to improve his strength, coordination, and balance in order to reduce his fall and in order to reduce his risk of falling. Other examples of functional rehab would be like gait retraining, learning how to transfer again from bed to wheelchair, from wheelchair to the toilet. And that would be the bulk of the rehab. In terms of discharge planning, I would consider discharging David from rehab in the hospital if he can do transfers safely, if he can walk short distances safely, even if a gait aid is needed. And I would play a role in deciding whether he would be transitioned to outpatient stroke rehab, like Toronto Rehab, or if he's good enough to just receive home-based care. And then after that, I would design a home exercise program in which he would continue to try to improve his activities of daily living, and also collaborate with the speech language pathologist to ensure that his therapy exercises can be communicated effectively.
Yeah. So from a speech language pathologist perspective, when looking at David, it has been identified here through assessment that David has expressive aphasia. So that being said, aphasia, he's having language difficulties. So we're looking at, can David communicate, I want help? I'm feeling tired. Can he communicate functionality in his language? So can he discuss his appointments, his physio appointment, what his concerns are? So we're really looking at what level or severity is that concern or language disorder or aphasia that he's experiencing right now. So the first thing that we would do is do a thorough language assessment. So I'd probably bring out a formal assessment, something called the Western Aphasia Battery. So that will help me determine the severity. Is he mild, moderate, or severe? If there is a severe aphasia presentation, we may need to look at using something called AAC, Augmentative and Alternative Communication? Are we using picture cards to help to communicate day-to-day needs? So depending on the severity would help us to determine what type of goals that we would be making. So a goal that might be created for David might be, David will express basic needs and wants with minimal verbal cues or visual cues 4 out of 5 opportunities. So for example, those examples, I need help, I'm feeling tired. And then this is where Kayla, the CDA, we would work collaboratively where I would discuss the goals with her, and then she would decide how she wants to create his actual therapy activities within the session. During the assessment process, we also want to make sure we're including his caregiver with him. What did communication look like prior to the stroke? So we know that we're trying to restore some functionality in his communication. So I'll pass it on to Kayla now, and she'll discuss the options in terms of therapy.
So yeah, speech therapy assistants, like we can work at the inpatient level or outpatient. So let's say David is still an inpatient in the hospital. After the goals are created, depending on the severity of his aphasia, I might go up to his hospital room and let's say he's severely aphasic, which means he's barely getting any words out. Like he's trying to communicate, can you close my blinds? Maybe he's pointing and he can't really communicate that. For patients that are that severe with aphasia, we might use some low-tech AAC. So I might print out like a green card that says yes, a red card that says no. Some patients that are even more medically complex might even just be able to use their eyes to communicate yes or no with one of those cards. I might have a communication board where he might get to point to something that he wants. I would be doing the training on those communication systems at the inpatient level. Also, again, if he is more severely aphasic, we might be using a communication device, a high-tech device. So I would be programming that, getting his vocabulary, teaching him how to use it to navigate the system. So we would be doing that training. On an outpatient level, I mentioned previously one of my volunteer experiences was at the Aphasia Institute. So that could be somewhere that maybe there's a referral for him. And in that situation, we'd be doing group settings. So I might be at a table with like 4 or 5 other patients, all with aphasia, and we're working on supported conversation. So that's actually a trademark term from the Aphasia Institute that's now worldwide, which means like as the communication facilitator, I might be helping to support conversation by maybe writing out some keywords on a piece of paper to help support the language comprehension. I might be using the AAC devices. Other types of therapy we can do. Again, word finding is also a big challenge for people with aphasia. So they know what they want to say, but they can't quite get the word out. It's very frustrating. So we might be using something like semantic feature analysis where we describe what they're talking about. Like if he's trying to tell me water bottle, but he can't quite get it out, what does it look like? What color is it? What do you use it for? So those are some things that we would do in therapy, as well as making it functional. If this is an adult who maybe he used to go to Tim Hortons every day and order a medium double, how can we get him communicating that effectively? So I would be doing some role play with him in the therapy session. So I'd pretend to be the cashier, for example. Okay, how can we work on ordering your coffee? If he has a communication device, I'd program that in. Sometimes we also make little cards saying, hey, I have aphasia. I know what I want to say. It just takes me longer to get out. Please have patience. So that's something we would work on as well to help facilitate those functional interactions to get him back doing the things that he used to do pre-stroke.
Awesome. Thank you. So clinical psychologist, I'm thinking about this client from a case conceptualization point of view. So this is someone with an ischemic stroke from the left side. So naturally, you're going to notice like some of those things, the reasons, right? Like right-sided sort of like difficulties, and then the speech. So this is something that a clinical psychologist may interact with both at the inpatient point of view, because a lot of clinical psychologists are actually very much integrated into some of the hospital departments like neurology and cardiology. So we might be there right at the sort of the patient's bed from the get-go. But most of the time, as a clinical psychologist, we're going to be seeing this individual post-stroke when they're medically stable, maybe after they've done significant rehabilitation, especially on the physical side, and they're now trying to integrate back into the community. So the way I kind of look at it Stroke is an acquired brain injury, and sort of as broadly speaking, there are three different areas that stroke might impact, right? Like their physical sort of capabilities, so speech and mobility, cognitively. So how is the stroke, especially the area in which the brain is injured, how is that going to impact their thinking skills? So things like memory, attention, executive functioning, verbal and visual skills, those type of things, as well as the psychological impact. So emotionality, their mood, changes to what their emotional experiences. And for David here, because he also has a history of mild depression to begin with, this is definitely something that we're going to be seeing as soon as the referral comes in. We're probably, as a clinical psychologist, likely to have received all of this information from our allied healthcare colleagues already through a report or information when I first see David. So my work, if we're looking at those three areas, includes, as a neuropsychologist, assessing this individual for their thinking skills. So how has their memory, attention, their ability to plan and organize, those types of things change as a consequence of their stroke? We'll also be looking at, from a rehab perspective, how has that affected his ability to integrate into his day-to-day? So things like as simple as communication has been disrupted, or his ability to access Tim Hortons and get his double-double has been disrupted. How is that then emotionally going to impact that individual? How is he coping with it? And as Dr. Hasina said, the caregiver burden, how is that going to then affect the people around him? So as a psychologist, that's where I'm going to be sort of integrating myself across these different areas. With David himself, we'll be doing potentially, after a thorough neuropsychological assessment that evaluates all of those different areas of thinking, what are the recommendations? What are the strategies that are involved to help supplement some of those changes that are coming? Either changes that are acute, or, as Raymond said, those that are more prolonged after that 3-month period. Having to live with those changes significantly alters that person's day-to-day functioning, how they view the world. So we're going to be looking at it from that remedial treatment perspective. How do we change and compensate for these changes, as well as the emotionality, the mental health side, especially with that interaction of a history of depression? How is that going to then affect how David views himself, his relationships, the world around him? So that part of it could be with talk therapy, psychotherapy. So an established gold standard form of therapy that maybe some of you are aware of is cognitive behavior therapy. That's the type of talk therapy that's very much involved with helping someone who's dealing with the stressors of everyday life cope with those realities, and how does that influence the way they then view themselves and their relationships around them. So those are some ways that a clinical psychologist may ultimately be able to sort of help with those three areas: the physical, the cognitive, as well as the psychological, emotional side of things.
Thank you. From a social work perspective, for David, the social worker would likely enter the case close to when David is ready for discharge. Our social work role, depending on the composition of the team, could involve looking at psychotherapy and looking at that emotional side, or it could involve more of a case management and a connectivity to resources. If we were on a team with a clinical psychologist who has already done a lot of the psychological analysis, who is connecting to talk therapy, then the social worker's role in this case would be more of connecting to resources. The social work perspective typically takes on like a biopsychosocial assessment. So the biological assessment will already have been covered previously from the team. So we would have received notes on, how the client was presenting, the support that was received, and kind of their level of functionality before we ever see them. We would have received notes on if they were receiving support already for like the depressive symptoms that they were receiving. So we would know kind of what are those gaps that need to be filled in as this client is getting ready to go back home if they're going home, or just to be discharged from the care of the facility. So we would look at things like the client's finances. The client isn't able to go back to work because of their physical limitations. So would be connecting them with social supports, seeing if they will qualify for supports like ODSP or OW. The client's wife is experiencing caregiver burnout. There's a caregiver benefit that's available through EI. So being able to connect them with resources such as that to try to alleviate some of those burdens that they would be facing going back home, as well as advocacy. So looking at, is there a possibility for this client to return to work? What might that look like for them? What supports might need to be in place if they were going to kind of go down that road? So just looking at connecting to resources and providing that support, are there community resources that they could be connected to? You know, as was mentioned, there is a serious issue with connectivity to primary care. So staying connected with his client, giving them referrals if they need to maintain access to, or to gain access to a primary care physician who would be able to provide them with ongoing care. Maybe connecting them with a community health center where they could receive support for some of the other issues that they're facing, like the diabetes that they're facing. And looking at how some of these issues are from the stroke and how the stroke has impacted them, even to pre-stroke, how that's impacting their lives, looking at cultural factors that might be impacting them. You know, as a member of the South Asian community, and they're experiencing isolation because they're just living with their wife. Like, how do they feel about the fact that, you know, they're going through this and their children are out of province and are far away in a culture that might be more collectivist and might be expecting more family support, right? How are those things impacting them, and how might they be supported kind of through that? Yeah.
Also, I really like to thank the speakers for this opportunity to learn in firsthand what is interprofessional care. So we saw the example of David, which had a stroke, and you can see all the care journey he had to engage and the amount of care he needed, health and social. And I think it's really unique having experiences where we can hear from a big group of the professionals that will be involved in his care. We can extrapolate this to all the other populations, like imagine a person with cancer, depression, mobility difficulties, etc. So thank you again for this incredible opportunity you gave us. And now we have around 20 minutes for question and answer. So feel free to ask about, again, about their personal journeys or the case study or anything that is of your interest. So feel free to listen. Yeah.
Thank you for that question. I myself right now, I'm primarily focused on Black and racialized clients. I think there's a lot of need in a lot of communities, but for myself, particularly with the Black community, and especially among Black men, there are not a lot of practitioners in an area where there is a lot of need. So I'm not limited to that, but that is the focus of my direct practice, and it is the focus of the research that I'm doing. I think, you know, there are a lot of communities that are underrepresented in terms of funding, in terms of support. And so I think if you have a personal connection, whether that's through your own personal experience or through professional experience, that would go a long way in terms of helping you to connect with those clients and connect with that community, which isn't to say that you can't serve someone from outside of your community. I think having an openness to learning and to growth is also important. But being able to serve a community, I think representation really does matter, and having clients that, whether it's through your culture, through your race, through your sexuality, that are able to identify with you and just have a comfort that there's certain things that they may not have to ask or may not have to explain, can go a long way. I hope I was able to answer your question.
I love that. I'm not doing any bad at all. I would be an actor.
Like for me as a hobby is photography, but I think like for more of a professional, like I think I would be in like teaching. Like like I had mentioned, a lot of my like passion for my area is because of like the mentors that I made while I was here at UTSC. So as a grad student, I had an opportunity to teach like undergraduate courses, and let me say it's a very different experience being the I guess course instructor on the other side. But that's something that I really enjoyed doing. So I would probably do something like that. And hopefully just like I had that experience of being inspired by like a professional who then ultimately could help me start my journey into clinical psychology.
I love traveling, so I probably would be a travel blogger if that was something that I could do.
Nice.
When I had moved to the UK a couple years ago before I got into speech, and I had started a blog, and it was really fun. And if I could make money off of that and I wasn't doing speech, that's what I would do.
I'm into photography as well. So I really enjoy nature. So if I could, I would probably be that guy that was like camped out in the snow for a month trying to get the perfect shot of a snow leopard. Yeah, that would be wonderful.
Yeah, I
Do
was
that
really
together.
trying to think too, like, what do I do in my free time? And right now it's just been reading a lot. Like, that's what I do when I do have time. So if there's a career in, reviewing books, maybe a book talk influencer,
Book
and so maybe a
editor.
book, yeah, maybe book editor. So maybe something to do with reading.
I think we have a question at the table.
I mean, I'll say, you can hear me. I definitely think it can get a lot. I think it was less competitive maybe when we were doing it. There was a lot of spots, but I would say be open to a variety of volunteer experiences. Like I remember it being really inconvenient for me, if I'm honest, to balance being at school and then taking the bus to go volunteer and then going back to work. It was difficult, and you're doing it for free. But just be open and try to think of, what you can get from it and what experience you're taking from it. So if it doesn't quite work with your schedule, try to be flexible and, put your resume out everywhere. I was putting it out in a million places to try to find a volunteer opportunity. For example, like I was able to volunteer 2 hours one day at Toronto Western Hospital with the SLP, and I was in Ajax at the time, and I missioned there just for that 2 hours. So if it's inconvenient, it's not always going to work, but I would just try your best to put it out everywhere and just take what you can.
Yeah, I think like have conversations with like your professors, course instructors. A lot of them, especially here at UTSC, have their own research facilities and research labs, and it's probably a little bit of an easy way to access it. I think something that we sometimes neglect is that all of us are working with people. So opportunities for you to like just interact day to day with people is a good stepping stone. And the way I've often kind of seen it is that any experience is good experience. Treat that as like a first step into something. So if you don't have experience interacting with people and you're interested in healthcare, that will be your first step. Don't even think about like necessarily going into working in a clinic or like a health facility just yet. Just being able to expose yourself to that. I always like to say my first actual volunteer research experience was not in psychology whatsoever. I was rearing black widow spiders in the science wing basements during a summer when it was really hot and pretty smelly. And somehow I made it into becoming a clinical psychologist. So it's just like, as Kayla was saying, just opportunities to just try new things. And sometimes you gravitate towards something, and other times you realize that you don't want to rear black widow spiders all your life.
If I could piggyback off of that really quickly, I was going to say as well, talk to your professors. You know, when I did my undergrad the first time, I was very insular, very to myself, and I had to kind of train and coach myself when I came back to go and to speak to my professors. And I realized like your professors, they want to talk to you. When your professors have office hours, go. Don't just go when you have a question. Treat it almost like a job interview where, you know, part of your preparation for an interview is when they ask you if you have any questions at the end. And so you like pre-prepare questions, generate questions to ask your professors, ask them about their research. The more your professors are exposed to you, to who you are as a person, to your investment in them and in their research, to your work within their class, the more when opportunities arise, you're going to be there in their minds. And yeah, so go to office hours, talk to your professors, ask them questions, make those connections, and network as much as possible. Because as much as that, like the way that the world is going, it really is who you know in a lot of cases, unfortunately. So whatever opportunities you have to network, like definitely take advantage of them, because if you're familiar, it's going to be a lot easier for you to get in the doors that you may want to get into.
Did you have another question for Hasina?
Thank you for that question. So there's really not a lot of difference. So where the difference usually comes between primary care nurse practitioners and physicians or primary care physicians would be the level of complexity of the patient. And that difference is more and more so prominent in acute care settings. For example, if you're working on neurosurgery, you have neurosurgery nurse practitioners, but you also have neurosurgeons that actually perform the procedures. In primary care settings, and I've been in primary care now for 8 years, there is really no difference between physicians versus nurse practitioners because we essentially do the same work. We work very closely with our physician colleagues as well, and usually that difference, the way the training of the physicians happens is a little bit different than the nurse practitioner training. So physicians are in school for a bit longer. They have a dedicated residency for 2 to 3 years to become a primary care family physician, whereas nurse practitioners do the master's degree, but they have some clinical experience before going into the nurse practitioner program. So when we're starting off as nurse practitioners, we always review with our physician colleagues, based on their experience and training. But as far as the scope of practice is concerned, it's usually based on knowledge, skill, and judgment. So if you're comfortable with a procedure or seeing certain patients, there is really no difference. Now, which one is more lucrative? Because I think the financial aspect is also important for a lot of people to know. So currently nurse practitioners are based or working on salary, so we're funded by the government. However, the Ontario government has approved for nurse practitioners to be able to bill starting April of 2026. So we're able to bill for our services. We're able to bill OHIP. For example, if I'm seeing patients in the clinic, I'm able to directly bill for those patients. Whereas in the past, usually the funding had to come from some pocket. So family health teams get funding to hire a nurse practitioner, and we were based on salary. But now it's the model is changing. We're going to see if this is helpful or not in the future. But right now, it has been approved by the Ontario government that starting April 2026 in the new year, we're going to be able to bill OHIP directly.
Honestly, the highest GPA you can get in terms of applying to schools in Canada, because it's extremely competitive. So they're really looking at those 5 electives that you need. I don't know if you've looked into them yet, where you need a few, like I think it's intro linguistics, you need a stats course, I think there was a psych, and there's also an anatomy or physiology. Yeah, and so in those prereqs, you really want to get as high as a GPA as you can, but knowing that there's a lot of international options too, and an adventure waits, but also volunteer hours. So, you know, I think there's a requirement for 13 hours. We had probably hundreds of hours in different speech environments. You know, I think that also helps with when you have to write your statement letter to personalize it a bit more for your range of experience already in volunteer opportunities. You know, also joining extracurriculars too. I think we had a very diverse application, which also helped us to get into grad programs. And then also just openness to apply everywhere and hopefully have that opportunity to accept wherever you do get in. Because when you come back to Canada, as long as you satisfy the requirements for CASLPO, which is that College of Audiologists and Speech Language Pathologists of Ontario, you can practice here as long as you meet the requirements. So yeah. Kayla, do you have anything to add?
Yeah, just really focusing on applying everywhere. We both didn't study. We both did our masters elsewhere. She did Australia. I did it in the States. It just happened to work out that way, and try wherever you can get in. It is quite competitive, but I think if you have a well-rounded application, they are actually looking for people to be in the field who don't always just specifically come from speech. Like there are a lot of people who had like music backgrounds and variety of backgrounds that can contribute to you being a well-rounded speech pathologist. So just really try to get volunteer hours and make your statement personalized as much as possible, because a lot of people use like, you know, AI and a cookie cutter statement, and it's not really that personal. So try to figure out how you can find your voice in that. Yeah, the Fascia Institute is great. I think that's a great experience to volunteer there. Grandview Kids is usually always accepting volunteers. March of Dimes Canada is usually always accepting. Those are more adult focused, but it still gives you a great foundation. So I would try those 3 are the first ones I can think of off the top of my head.
And maybe applying to private clinics that have a clinic space.
Yeah.
So for example, volunteering with us is kind of tricky because we're remote. We're driving from client to client, right? But clinics that have a space where you can go to for the day for a few hours, like, you know, that might be ideal. So I would definitely contact the private clinics with the space as well. Yeah, no problem. This is had a question. Oh.
I was just wondering, you were talking a lot about networking with professors, and some of my classes have like upwards of 1,000 kids in it. Everyone is, you know, hearing that advice and trying to help those professors specifically. So I was wondering what you would do in those situations.
Be persistent. You'll have large classes. You'll have people that are very motivated, but being very motivated consistently, I think will go a long way as well. So like, just keep showing up. I think if you're able to branch out beyond just your professors and see like, if are there things that are happening within the department, events like this, or I know within the sociology department, sometimes they, when I was here, they held like classes to prepare you for your grad school application, which was, I did that and was able to get connected with like 2 other professors. So just like keep your ear to the ground with what's going on within the school, and just like show up and participate. Because you're right, like it's a lot of people and it's competitive, right? And it's not an easy road, but you just have to continue to be dedicated and just continue to show up.
Just look up the profile of your professors. So at TMU, we have our own profiles that are posted and they're public. So if you're in a class and your professor is always bringing in certain examples of their research, look at their profile. On their profile, usually they say they'll be accepting volunteers, the kind of research they're doing, and their email is usually listed on there as well. So give that a shot, you know, maybe send them an email, let them know. If they're doing publications, for example, if they're writing a lot, you might be able to get involved in that part of it, or if they have a current study and they're looking for research assistance, you can express your interest in that perspective as well. But like Greg said, being persistent, because if we haven't had the students in that class, then there might be a few emails coming through, but you might be one of those students that is more persistent in sending a few emails, follow-up email, check with that. But definitely look at their profile, see what kind of research they're doing, and if that is of interest to you or not, and you can contact them.
I was just, we have like 2 minutes left before Professor Silver wraps up the event, but I wanted to add, as a new assistant professor here at the Department of Health and Society, I've been receiving emails from students. I'm interested in the research you do. And something it's really important is like, do it personally, don't use AI tools, because I could clearly see when they pull up my papers and try to write some AI generated, as opposite that when it was really personal, and those students, I might be more responsive to them probably. So if that, it's a really practical advice. So.
Thank you. Thank you so much. Wonderful. Really appreciate your thank you, everyone. And we can take a few questions.
Okay.
Now, informally, but I want to close the formality.
Thank you so much again. It was
Yeah.
Yeah, that's good.